A very good evening to all of you. The title of the study which I am going to present today is Hidden Orbital Inert Foreign Body, a tale of two cases. It's not moving. It's not moving. So orbital foreign bodies are encountered whenever there is orbital and facial trauma. Organic foreign bodies are removed along with some metallic foreign bodies, as it can cause severe inflammation and infection. However, inert foreign bodies are left behind when it is located near to optic nerve or orbital apex. In cases where foreign bodies are not removed because of its inert nature, this patient should be followed up regularly to look for its remote effects. So herein we report two unusual cases of hidden orbital foreign body, which was initially presumed to be inert, but later presented with vague symptoms and which misled the diagnosis for few days. So our first patient presented with an injury to his right eye 20 years back, followed by he developed sudden diminished vision in the same eye. He was diagnosed as a case of open globe injury, and CT orbit was done which showed intraorbital foreign body which was deep seated. So he underwent wound exploration and primary repair. However, the inner foreign body was not removed at that time because it was thought to be of inert nature. Patient was then lost to follow-up, and then he again presented in 2019 with an episode of upper eyelid swelling. He underwent IND and he underwent biopsy also, and we suggested inflammatory etiology. However, his condition did not improve and he sought consultation at our center. So ocular examination showed no perception of light in the right eye, and left eye it was 6 by 6. Clinical examination showed right eye upper eyelid swelling with a mechanical ptosis, and slit lamp examination showed triangular vascular mass which was encroaching upon cornea, and other details could not be visualized because of the corneal opacity. The left eye examination was essentially normal, and CT orbit was done which showed hyperdense extracorneal lesion which was located in the supromedial expert and which was abetting the superior rectus and the medial rectus. So he underwent anterior orbitotomy, and 10 mm size stony foreign body was removed from the affected side. He recovered completely within 2 weeks, and he did not show any sign of recurrence at 6 months follow-up. So our second patient presented with a complaints of watering from left eye, and he had given a history of injury to the same eye with a splinter 2 years back, but no intervention was done in that time, and no visible wound was found. But 1 year following injury, he started experiencing watering from the same eye. So anti-segment and fundus evaluation in the both eye were essentially normal. Lacrimal irrigation test was done which showed patent passage in the right eye, and in the left eye it was heart stop was found, and there was a regurgitation through opposite puncta. So he was diagnosed as a case of chronic dacrocystitis left eye. CT orbit was done as he had given a history of injury, and we showed hyperdense lesion extracorneal in the infromedial part which was abetting the optic glove. So he underwent external cystorhinostomy, and during fashioning of the lacrimal and the nasal mucosal flap, the foreign body was noticed in the infromedial part, and it was removed in total, and it appeared to be part of the steel. So as per traditional teaching, inert foreign bodies are not touched as chances of infection are very rare. However, patient harboring these inert foreign bodies sometimes can present with vague symptoms and confusing clinical picture. So in our first case, the foreign body was not removed at initial presentation, as it was thought to be of inert nature, but the importance of regular checkup was not emphasized. So over these years, the foreign body migrated anteriorly and got lodged in the supromedial part, and which resulted in the recurrent episode of upper eyelid swelling. So second case presented with a watering after 1 year following injury, and he was advised external DSI, it was attributed initially to nasolacrimal duct obstruction. However, during surgery, the foreign body was found in the infromedial part, which was obstructing the NLD. So this case demonstrated that there is a possibility that foreign body can get lodged within the orbit in the absence of external wound. And we speculate that the foreign body must have traveled with high velocity to the lower fornix at the time of injury. So Carroll et al. Also reported patient became symptomatic 27 years after injury, and Nair et al. Also reported in the communication that patient became symptomatic 13 years after injury. So to conclude, inert foreign body can pose a serious diagnostic challenge It can also have grave consequences like organic and metallic foreign body. And through these case reports, we want to raise awareness about the potential complications which are associated with foreign body and which is very crucial for the proper care of the patient. So these are my references. Thank you.